I'm very aware that some of the people in the audience have been recently diagnosed with pancreas cancer, and I know that the idea of pancreatic cancer screening may not be directly applicable to you who have been recently diagnosed, but I'm certainly hopeful that some of the information that I'm going to present today may help you to determine if it's likely that an inherited factor has contributed to your diagnosis, and whether any of your relatives may benefit from having screening. As Sonia mentioned, I am going to be talking about quite a number of aspects today, and so I just wanted to begin by just outlining the topics that I plan to cover. So I'll begin by talking about what causes pancreatic cancer, who might have an inherited risk of developing pancreas cancer, and more about what that risk is if there is a faulty gene in the family or a family history. And then if you do have an increased risk, what can you do about it? I obviously want to go into a lot of detail about why we're running a pancreatic cancer screening trial, exactly who we recruit and what's involved, as well as giving a bit of a general discussion around some of the potential benefits and also some of the potential risks of screening. Because I'm going to be talking about quite a few different things, I plan to just summarise these into some take-home messages for you. And then obviously I hope to still leave plenty of time for any questions that come through. So, what causes pancreatic cancer? We know that majority of pancreas cancers are sporadic, meaning that only one person in a family may develop that disease. And it is typically caused by environmental factors. Now, some of these environmental factors we can't actually do anything about. Age, for example, is a known risk factor for pancreas cancer. We know that when pancreas cancer occurs, it is most commonly diagnosed over the age of 70. We know that males have a slightly higher risk than females for reasons we don't really understand. But there are also a number of lifestyle factors, with the highest risks linked with smoking, being overweight or obese, and diabetes, particularly type 2 diabetes. Other conditions that cause chronic inflammation of the pancreas or exposures to certain toxins, including alcohol, can also significantly increase a person's chance of developing pancreas cancer. In the more recent years, though, we've really started to realise that a small proportion of pancreas cancers, currently believed to be about 10% of all cases, are linked to an inherited factor. And that factor could be that the individual diagnosed with pancreas cancer has a specific faulty gene that causes a known cancer predisposition syndrome, or it could be that there are many relatives within that family that have developed pancreas cancer. And even though we may not know what that specific gene fault or genetic cause is, we do have a name for this, and this is called familial pancreatic cancer. So how can we recognise those individuals that have an increased risk, and what exactly is their risk of pancreas cancer? So this table lists the most common syndromes that we're currently aware of that are linked with an increased lifetime risk of pancreas cancer. And if we compare these figures to the risk of about 1 to 1.5% in the general population, you can see that some of these conditions, particularly hereditary pancreatitis and Poites-Jäger syndrome, are linked with a very, very, very high chance of developing pancreas cancer, particularly if an individual with those conditions is also a smoker. As we move down the table, we can see a couple of other conditions like familial atypical multiple mole melanoma, hereditary breast and ovarian cancer, and Lynch syndrome. And these have high risks of pancreas cancer as well, but you can see that the overall lifetime risk is still lower than that of the first two conditions. If we look more closely at hereditary breast and ovarian cancer, we know that this syndrome is caused by faults in the BRCA1 and BRCA2 genes. And because we've known about these genes since the 1990s, researchers have been able to track the incidence of pancreas cancer within families that have faults in these genes. And we've got evidence that shows that the risk for people with faults in the BRCA2 gene is about a 5% risk across that individual's lifetime. However, the data for BRCA1 is a little bit less conclusive. Some studies have shown that there is an increase in risk for people with faults in BRCA1, and other studies have shown that there is no significantly increased risk for BRCA1 carriers. And so at present, our best estimates for those individuals is that their lifetime risk of pancreas cancer is less than 3%. More recently, some newer genes, including PALB2 and ATM, have also been linked to an increased risk of pancreas cancer. We've not yet really had enough time to track the incidence of pancreas cancer in families with faults in these genes, but the evidence to support an increased risk in pancreas cancer has really come from doing more genetic testing in individuals who were newly diagnosed with pancreas cancer. And we are finding a higher proportion of people with faults in these genes than what we would expect. So it certainly does seem that there is an increased risk for people who have faults in PALB2 and ATM, but we've not yet been able to put a figure on what that particular risk is. Taking all of these syndromes though together, they still only account for about 20% of all high-risk families. The other families are classified as having familial pancreatic cancer. By definition, familial pancreatic cancer is the presence of 2 or more first-degree relatives in a family that have been diagnosed with pancreas cancer. And if we think of a first-degree relative, we mean a parent or a sibling. So, as you can see in this table, the risk to people in a family whose history is consistent with familial pancreatic cancer is known to increase with the more relatives that they have that have been diagnosed with pancreas cancer. So if an individual has one first-degree relative, say a parent with pancreas cancer, then their risk is estimated to increase to about 4% across their lifetime. Those who have 2 first-degree relatives, so a parent and a sibling, then their risk is estimated to be about 8 to 12%. And a person who has 3 or more first-degree relatives, their risk is higher again. It's not just the number of people in the family that have been diagnosed with pancreas cancer. We know that if there's a particularly young diagnosis of pancreas cancer, that it can also increase the risk. And anyone who has this family history and also is a smoker, they have an increased risk again, chance that they would develop a pancreas cancer at a younger age. So because we now recognise that there are certain families where there is an increased risk because of inherited factors, we're now seeing more people being referred to a genetics service at the time of their diagnosis with pancreas cancer. And this is important because it can obviously provide helpful information to that individual. It may modify certain treatment plans for them, and it can also identify if any of their relatives have an increased risk as well. And the reason it's really important that a person be referred to a service if they have been affected by cancer themselves is because genetic testing for cancer predisposition is always most informative and most helpful when it's the affected member of the family that is tested first. I've listed a couple of points here for when people should be at least consider a genetics assessment, and that is any individual diagnosed with pancreas cancer under the age of 50. Though I've also made a comment that some services are now recommending anyone diagnosed under the age of 70 have a genetics assessment. That doesn't mean that genetic testing will always be offered, but it is certainly appropriate to have a family history assessment. If there are 2 or more relatives in a family diagnosed with pancreas cancer, particularly if they are first-degree relatives of each other, then the family would meet familial pancreatic cancer criteria and a genetics assessment is certainly appropriate. If there is a personal diagnosis of pancreas cancer and that person has a family history of certain cancers like breast, ovarian, or other gastrointestinal cancers, particularly if there are some young ages of diagnosis, then again, a genetics assessment is appropriate. And of course, if anyone is aware that there's already been a faulty cancer predisposition gene found in a blood relative, then other members of the family should be informed of that information so that they can consider if they wish to have their own genetic testing. Even if a person sort of doesn't meet those criteria, we're also seeing more interest in oh, can you guys still see me? Oh, I've just lost my slides, sorry. Here we go.
I can see the slides.
Yeah, sorry, they just disappeared from my end for some reason. So we are seeing an increased, some people are interested in the option of self-funding their own testing, and as the cost of genetic testing decreases, this may become a more feasible option for some people. So just down the bottom of that screen there, I have included a link to the Centre for Genetics Education website where they list all of the cancer genetic services in Australia. So if a family or an individual is found to have an increased risk of developing pancreas cancer, what can they do about it? The number one thing that people can do is to control their environmental risk factors. Now, none of the things on this particular slide are things that would surprise anyone. We know that we're all encouraged to avoid smoking, limit alcohol consumption, maintaining a healthy body weight through diet and exercise. But everyone, or many people, including myself, struggle with a few of these things. But when there is an inherited risk of developing cancers, particularly pancreas cancer, controlling these modifiable risk factors becomes really important. The other thing that a person can do is have regular checks of their pancreas to hopefully detect any signs of abnormalities or cancers. And the idea of pancreatic cancer screening really came about when the CAPS consortium, the Cancer of the Pancreas Screening Consortium, formed in 2010. This consortium is a group of over 35 different research centres all around the world, and they're working together to coordinate a global approach to pancreatic cancer screening. These trials are still being conducted in a research setting because we are still developing the optimal protocols to screen the pancreas. And because of that, there are currently quite strict criteria about who is recommended to be involved in these studies. And we currently limit recruitment of individuals to those who are considered high-risk individuals, which are those that have a greater than 5% lifetime chance of developing pancreas cancer. So why is it that we're running this as a screening trial? Why isn't this something that we just do for everyone in the population? I do have some statistics on this slide, and I certainly hope that the information is not too confronting for some of you in the audience, but we know that pancreas cancer is reasonably rare, at least compared to some of the more common cancers in the community like breast, prostate or bowel cancer. It's estimated that in Australia there'll be just over 3,900 new cases diagnosed, and unfortunately most of those individuals will be diagnosed at a late stage where treatments are often ineffective. Because of that, we've made little progress in our overall survival rates for individuals diagnosed with pancreas cancer. But the good news is, particularly over the last decade, we can see that there is slowly an increase in the 5-year survival rates, and for the first time we have achieved a greater than 10% survival. So whilst we've only got a small number of people who are diagnosed each year in this country, we need to do something to improve our survival rates. Because there are so few people, population screening is not feasible. But if we can identify those who have the highest chance of developing a pancreas cancer and inviting those individuals to participate in a research study where we can hopefully generate evidence of a benefit for screening, then this becomes an appropriate strategy for us to do this research. This figure shows our current understanding of how pancreatic cancer develops. And as we move from the left-hand side of the slide, where we've got normal cells of the pancreas, we can see that over time, and that period may be months or years, the cells of the pancreas develop abnormalities. And at first, these are lower grade lesions. These lesions are called PANINs, or pancreatic intraepithelial neoplasms. And these low grade PANINs can further change into a higher grade PANIN, a PANIN 3, and then that higher grade lesion can become an invasive cancer, which ultimately spreads and metastasizes to other parts of the body. And it is typically only after the cancer has spread to other organs that a person develops symptoms and their cancer is diagnosed. The overall goal of screening is to identify an early cancer, or even better, to identify a PANIN 3 lesion before it has become an invasive cancer, and to offer treatment or an intervention at that point to ultimately improve the outcome for that individual. The challenge is that we've still got no proven evidence that early detection has a positive outcome for those individuals. But we do have some very encouraging preliminary evidence. And to support this, I've just listed two studies. One by Liu et al. In 2015, who reviewed 16 individual screening studies and showed that if a person's cancer was detected during screening, that a greater proportion of them were able to have surgery that was intended to cure them of their disease, and importantly, that the patient survived longer. More recently, Canto et al. In 2018 published the first long-term study, and they showed again that the majority of people who had a cancer detected through screening were operable, and that if a cancer was operable, a greater proportion of them were still alive 3 years after their diagnosis. The difficulty for us, though, is that the actual number of people who were diagnosed with pancreas cancer during these studies is really small. Now, that's actually really reassuring for you guys, because what that means is that even in a group of high-risk individuals, majority never go on to develop a pancreas cancer, but it does make our job more difficult because it takes us longer to generate this evidence of a clinical benefit. And so what the studies are doing now is they're all pulling our data together into one big group of patients so that we can hopefully get this answer quicker. So what do we do in the Australian Pancreatic Cancer Screening study? Who are we recruiting and what's involved? So we recruit individuals whose family history meets the criteria for familial pancreatic cancer if they are aged between 50 and 80 years of age, if they have 3 or more relatives on the same side of the family who have been diagnosed with pancreas cancer, with at least one of them being a first-degree relative, or if there are only 2 cases of pancreas cancer in the family, then both must be a first-degree relative of the person being screened. We also recruit individuals who have a clinical or a genetic diagnosis of Peutz-Jeghers syndrome and hereditary pancreatitis, irrespective of their family history of pancreas cancer. And we also recruit people who have faults in the BRCA2, PALB2, CDKN2A or Lynch syndrome genes if they are aged over 50 with at least one first-degree relative of pancreas cancer. We do not currently recruit BRCA1 carriers, and as you may remember from my earlier table, that's because BRCA1 are currently understood to have a moderate risk, but not a high risk of pancreas cancer. And we don't recruit people who have a faulty gene without a family history of pancreas cancer. There are also some health conditions that make screening unsafe. And so I've listed the main ones there, but we do always suggest that if a person has a health condition that they think may influence their suitability to undergo screening, that we actually have a one-on-one chat about that, and we can determine what we can do for you. The test that we use as part of our screening program is called an endoscopic ultrasound. So for those of you in the audience who have been diagnosed with a pancreas cancer, you may already be familiar with this technique because it is currently used in the diagnosis of pancreas cancer. An endoscope is a long, thin, flexible tube that has a camera and, in this case, an ultrasound probe on the end. Whilst under sedation, the endoscope is inserted into the mouth and directed down into the stomach, and it can sit at the base of the duodenum. And from there, it can take an internal image of the pancreas, which looks a little something like this. Sometimes the doctors may see a lesion within the pancreas that is suspicious for a cancer. And in that scenario, the other benefit of an endoscopic ultrasound is that it has a small needle on the end as well, which can take a biopsy at the same time. So as I mentioned, this is a technique that is currently used in the diagnosis of pancreas cancer. So it is a safe and established technique in gastroenterology. It's just its use as a screening tool for pancreas cancer that is under investigation. If a person joins our study, we ask them to complete a consent form, as well as a baseline personal and family history questionnaire. A genetic counselling appointment is part of the study, and that may or may not include genetic testing, depending on the family history. We offer an annual endoscopic ultrasound and blood test. The blood test includes some basic clinical markers, but we're also trying to develop a new way of detecting pancreas cancer early in the blood. Now, if that endoscopic ultrasound is normal, we simply continue an annual EUS for 5 years. If that finding is abnormal, though, we may need to keep a closer eye on the pancreas with a follow-up procedure at 3 months or 6 months, or we may need to intervene and offer treatment in the event that a cancer is diagnosed. This part of the study really helps us to determine the progression of lesions within the pancreas, when to time intervention, and obviously, hopefully, to determine if there is a clinical benefit of early detection of pancreas cancer. After the first endoscopic ultrasound, I give the participant a brief follow-up call just to check in and see how they found the procedure. And then we ask participants to complete 3 brief follow-up questionnaires, 1 month, 1 year, and 5 years after their first EUS. And this helps us to assess the psychological impact of screening, so really get an understanding of the experience of being involved in the study. So we've been running this study at St Vincent's in Sydney since 2011, and it expanded to Austin Health in Melbourne in 2015. We are still recruiting at St Vincent's in Sydney, though there are a few delays at the moment because of COVID. We've recently also opened an additional site at the Royal Brisbane Women's Hospital. Understandably, things are on hold at the moment at Austin, but we do hope that they'll be picking up again early next year. And we also have an additional site coming shortly in Perth. So we've now been able to set up essentially 4 centres across the country that are now offering pancreatic cancer screening in Australia. But I know that not everyone lives in those capital cities, or not everyone can feasibly travel to those capital cities to access screening, or it may be that a person may not meet our strict inclusion criteria, but still have an interest in having some screening of their pancreas. So if this applies to you, what I suggest is you start by having a chat to your GP and to really ask your GP for a referral for two different services. The first is to see a cancer genetic service. Obviously, I'm a little bit biased because I am a genetic counsellor, but it is appropriate for anyone who has a family history of cancer, particularly several cancers, to have an initial family history assessment. That can help determine if anyone in the family is recommended to have some genetic testing, and it can also allow that individual to receive personalised screening advice. The other referral to consider is to see a local gastroenterologist. Now, not all gastroenterologists are familiar with pancreatic screening, and some may not offer this service, but some may be able to provide privately funded screening. Endoscopic ultrasound is a specialised technique in gastroenterology, and it's not something that all gastroenterologists do, but some of them may arrange other screening tests like an MRI or a CT. So just to give you a little bit of information about those screening tests, we know that they all have pros and they all have cons. If we take MRI first, we know that it actually shows a lot of detail. This particular technique uses radio waves and a magnet rather than radiation, but it does take longer. It is a loud and enclosed machine, which some people can't tolerate, and it's also expensive. And at the moment, there is no Medicare rebate for the purposes of these tests to look for pancreas cancer. So these are out-of-pocket expenses. A CT, on the other hand, is a shorter procedure and less expensive, though it does expose the person to radiation. And we have some data suggest that CTs are not as good as EUS and MRI. And this data really comes from a study from back in 2012, where Canto et al. Had a group of 216 screening participants, and they found that 42% of those had one or more abnormalities of the pancreas. Now, before people get too worried about hearing a report of 42% of people with an abnormality, it's really important to note that none of these individuals had a pancreatic ductal adenocarcinoma. 84 of these people had one or more cysts in the pancreas, 3 had a solid lesion, and 5 had a dilated pancreatic duct. Each of these screening tests missed some of the lesions. You can see that CT and EUS missed a small number of the cysts that were seen by MRI, whereas CT and MRI missed a small number of lesions that were detected by EUS. And this did include 3 neuroendocrine tumours. Neuroendocrine tumours are a very different form of tumour compared to a pancreatic ductal adenocarcinoma, and they do have overall much better survival rates, though it is still important to be aware of these tumours. As we can see in the table there, if we look at overall the total number of lesions, EUS and MRI had a similar detection capability, whereas the CT obviously missed a number of those lesions. And based on this data, the international screening trials have stopped using CT as the primary screening test, and each of them use either endoscopic ultrasound or MRI, or a combination of EUS and MRI. The other question that I get asked a lot is there a blood test to detect pancreas cancer? And unfortunately, the answer is, well, at the moment, blood tests are just not currently useful. There's been a lot of work in this area, but so far we've not been able to find a good marker for pancreas cancer in the blood. There is one marker that some of you may be familiar with. It's called CA199, and it is currently used in the diagnosis of pancreas cancer. And it can be useful to track how well a person's pancreas cancer is responding to treatment. But generally, this marker has what we call low sensitivity and specificity. What that means is it actually misses about a third of people who are diagnosed with pancreas cancer, and we know that other people who don't have a pancreas cancer can actually have a high level of this marker. So it doesn't really identify everyone appropriately. The other blood test that some people use is a simple fasting glucose. And this is because there is some evidence that if a person suddenly develops diabetes, that it could be that they've got a pancreas cancer. The difficulty is in an area or in a world where we have a large number of people who suffer with diabetes, it's impossible to determine who has developed diabetes because there's a cancer in their pancreas, as opposed to who has just developed diabetes. One area where a lot of research is currently going into is this concept of a liquid biopsy. What this test does is it circulates DNA that has been released from the cancer cells and can be detected in the bloodstream. This is not something that is currently available, but we certainly hope that this might be something that is available in the next 5 to 10 years. Though I guess we've still got a lot of ways to go to know exactly how expensive this test is going to be and who is going to have access to it. So what are the main potential benefits for screening? Obviously, the overall goal is that we may find that a person has a pre-cancerous lesion or an early cancer, and we can intervene and begin treatment early and hopefully improve their clinical outcome. If we do regular checks on a person's pancreas and we report that everything is looking normal, we can hopefully provide reassurance to that person. And of course, importantly, it would be a way of helping researchers to understand how pancreas cancer develops and how we can detect it early. But on the flip side, what are the potential risks? Unfortunately, all screening tests have risks. So if we firstly think about the EUS that we use, it is an invasive technique and it does have some possible complications. Some of these complications are quite minor. The one that I hear most commonly is that a person might report that they had a sore or scratchy throat for 2 to 3 days after the procedure. Some people mention that they felt a little bit drowsy for about 24 hours after undergoing sedation. A more severe complication could be the development of pancreatitis. That's typically only something that is of concern if a biopsy is required during the EUS. And at the very, very extreme end, although thankfully very rare, the endoscope could cause damage or perforation of the esophagus. The other screening tests, though, have risks as well. With the MRI, it does expose the patient to a contrast agent. In the last year or so, we've moved away from using gadolinium-based contrast agents, but these agents can still cause reactions in some patients and can cause some kidney problems. The MRI, as I mentioned, is not suitable for some people if they experience claustrophobia or if they have a medical device or metal implant in their body. And with CT, it does expose the person to radiation. As a once-off diagnostic test, that level of radiation is low and is not a problem. But if a person was going to have a CT scan every year for 15 or 20 years, that amount of radiation will go up. The other potential risk is that we actually still have limited data on the long-term outcomes about whether or not we are improving the course of illness or improving survival for individuals. And because of that, the benefits of screening may not outweigh the potential risks. And along the same lines of that, we might also be providing false reassurance to people. There is also a chance that we might find an uncertain or an incidental finding, which might mean that we'd need to arrange some additional tests, or we may intervene and do a surgery for a lesion that was never going to develop into a pancreas cancer. All of these things can increase the worry or the anxiety experienced by that individual. The final potential risk is really a logistical or a financial one, and that is, although being involved in the study doesn't cost the person anything, they do need to self-fund any travel to those sites to participate, or if they're wanting to seek their own insurance, their privately funded screening, that's something that they would, that's a cost that they would incur. Specifically for the EUS, because the procedure does involve sedation, you can't drive yourself home afterwards, so we always need that person to have a support person to escort them home afterwards. So there are a few additional challenges that people need to consider. So I know I've given you an awful lot of things to think about. What are my main take-home messages? Number one, some people have an increased lifetime risk of pancreas cancer because of their family history or because they've been found to carry a faulty gene. However, even when we look at high-risk individuals, they are still more likely never to develop a pancreas cancer. If a person has an inherited risk, then controlling their environmental risk factors becomes really important. High-risk individuals can also access screening through a research study or perhaps privately with a gastroenterologist. Screening trials are still generating evidence of a benefit, but we do have some preliminary data that is encouraging, and we're actively moving towards hoping to get more publications and more evidence out there. And there are both potential benefits and potential risks for screening, and I encourage everyone to really weigh these up in relation to your specific circumstances. So with that, I thank you very much for your attention, and I will happily take any questions.